I know that Dr. Grotkow, who is the chief of pediatric orthopedic, and surgical services at Holtz Children, he's going to share with us today. He has a focus on scoliosis and pediatric spine surgery, and he's actually doing a surgery today. So we're gonna get started so we can squeeze out every ounce of our time with our expert today. But he has co-developed a groundbreaking surgery called the anterior vertebral body tethering. So you could tell us more about that, which helps children with scoliosis regain their normal spinal function. That is just incredible. Dr. Grotkow, thank you and welcome.
Thank you. Thanks for having
We
me.
I love this series because we really get to sit down with the experts, not just a representative from Jackson, but truly the expert in the category that we're speaking on today. So I want to tell our audience just a little bit more about you, but you are the UHealth Jackson Children's Care Chief of Pediatric and Orthopedics. Also, like I said, the surgical services at Holtz and a professor of orthopedics and Shriner's Children's Endowed Chair in the Pediatric Orthopedics at the Miller School of Medicine. I don't know when you sleep. Do you ever get any sleep with all that you have going on?
Oh, I get plenty of sleep.
Well, good, good. You sound like a very busy man. Dr. Grotkow is also an accomplished board certified orthopedic surgeon and researcher who specializes in pediatric orthopedic and adult spine disorders. He received his medical degree at Harvard Medical School and completed an orthopedic surgery residency and fellowships in spine surgery and pediatric orthopedics at Massachusetts General and Harvard Medical School in Boston. His interests are a wide array. Like I mentioned before, we're going to talk about scoliosis, this anterior vertebral tethering, as well as vertebral body tethering. See, I can't even say these words, and you're developing whole entire surgeries. This is incredible. We're excited to learn more, and we want to pick your brain about the skeletal system, clubfoot, hip, knee, leg disorders, all of that. So if you're listening and any of these words are kind of hitting a trigger for you, put those questions in the Q&A and let's get them in front of our experts. So all right, I'm ready to get started because I have a list of questions and I want to let's start at the very beginning. We have some people listening who maybe have little people, and so they're just looking at those first milestones of development. But can you talk to us, when do children typically start walking and what should we look for? And then we're going to go on from there.
Thanks. That varies a reasonable amount. But on average, I think most developmental milestones are sitting independently at 6 months and starting to take the first steps somewhere around a year. But it can be as late as 15 months and such. And
That's right.
my personal experience, and I don't know if this is backed up by literature, but I think firstborns are a little slower at getting up and walking. And
We dawdle them too much, don't we?
well, that's what my mother said with our first. She visited from California, and I said, "Geez, I'm a little worried. He's 15 months and not walking." And she goes, "Well, from what I can tell, he doesn't need to." So,
That's right.
thanks, Mom. But you know, uh, and then the ones that come behind are kind of looking to keep up with the first. So my experience has been that they tend to get up and moving a little earlier, but usually we'd say 15 months. Now, we do if someone's not walking by about 16 months and it's a male, specifically a Caucasian male,
Okay.
that sometimes we worry about things like muscular dystrophy. I'm not trying to worry people, but one of
Right.
the things we'll do is that sometimes we'll do a quick blood test and just make sure it's not something abnormal, because people are in their reproductive age of life, and if someone, you want to make an early diagnosis in that because it's a genetic
Right.
condition. And so we'll sometimes run a test that someone's, if a white male is a Caucasian male is not walking at, let's say, 16, 17 months, but and just to make sure that we don't see anything abnormal there.
Okay, and that can be done, you're saying, with a blood test to
Mm-hmm.
determine that. Wow.
Yep.
Okay, I had no idea.
Yep.
Interesting. All right, let's talk about, is it normal for children to be bow-legged or knock-kneed? And talk about the difference. I think we know, but talk about the difference.
Sure. Bow leg is like this. Knock knee is like this, and so yeah, the kid's growth is a moving target, and there actually this was first described in 1930, believe it or not, in an article in the Journal of Bone and Joint
Wow.
Surgery by a guy named Selenius. And so they looked at kids, and they find that when babies are born, they're bow-legged, and then they start coming from bow-legged to neutral by about 18 months of age. And then 18 months of age to about 4 years, they become knock-kneed, and they're pretty much maximally knock-kneed at 4 years of age. And
Okay.
then from 4 years to about 8, they start coming back to their adult configuration, which is slightly knock-kneed. So,
Interesting.
you'll see kids early on that parents are concerned about bowed legs, and for the most part, it's probably not a big concern because it's just a normal part of development. And then they'll come in at 4 years of age because the kids are knock-kneed, and they're a little concerned about knock-kneed, and so education and talking them through usually is all that's required.
Wow, I'm on kid number 5 and I've never heard that piece of information. So that I
Oh
feel
yeah.
like that's a good little nugget to know. We've all seen the babies that waddle like this with their legs out, and you think, okay, so that's a normal part of our growth and development. Okay, up
Yep.
until age 4. So let's talk about flat feet and what is the common cause of flat feet in children?
Oh, so flat feet, generally we don't worry about flat feet, first of all. A lot of people do get worried about flat feet, because they see their kids, but it's a pretty normal thing in young kids. Part of it is because young kids are pretty ligamentously lax. And as you get older, you get tighter. I mean, any of us who, you used to be able to do splits when we were teenagers and try to do it now, you end up in the hospital. So
That's
we all
right.
know we get a little bit tighter and stiffer as time goes on. So do kids. And so it's pretty normal to have flat feet when you're young. First of all, there's a lot more subcutaneous fat, and that's true in the feet as well. And so generally, flat feet tend to resolve at around 6 years of age if they're going to
Okay.
resolve. But as long as they're flexible, we don't really worry about them, right? It's only stiff flat feet or stiff and painful flat feet that we worry about. And that's a really small sliver of kids with flat feet. And basically, the test we use to determine is if they stand up on their toes and they have a reconstitution of their normal arch, in other words, the hind foot, the heel swings what we call into varus this way,
Okay.
then it's a flexible flat foot, and there's generally nothing to be concerned with. You don't generally need, unless it's really extreme, inserts or anything like that, arch supports or such.
Okay. So all the marketers out there that are selling us the best orthopedic kids shoes, maybe it's not necessarily necessary yet.
Oh no, no, that's just playing on guilt, and
Yeah. People
it's a
know,
good
don't they?
marketing. It's a good marketing thing.
Those marketers, they know. Okay, this is great information. Again, these are things that we don't think about every day, but that affect all of us, and all of us are dealing with these things with our children. Okay, you talked about how obviously the kids, their bodies are moving, they're growing, they're getting tighter. At what age do children typically stop growing?
Depends on, girl or boy. And again, we're going to talk typical. So generally, girls will grow for 2 years after the onset of first period, even if it's
Okay.
not regular. So for most girls, that's around 14 years of age,
Okay.
when they stop growing. So most girls have periods at 12 years of age. There are girls that have periods that, it's becoming a little bit earlier and earlier. And there's a lot of theories behind that I won't even
Okay.
get into. But if your daughter has a period at 10 years of age, she may not only be growing till about 12. Boys are usually a couple years behind them, right? So most boys will
Right.
grow to 15 or 16. And, but that again varies as well. There's some people that grow a lot later, but that's just if you're looking at the center of the target.
That generalization, yeah, that's good. Okay, this is very on point for where we are today. So I found myself in the middle of the night with a 5-year-old crawling in my bed, crying, "My legs hurt, my legs hurt." And I'm half asleep. I think you're growing, you're fine. But so let's talk about growing pains, and maybe or maybe not, that's what he was experiencing. But we all kind of hear our kids say these things. So how do we manage our children's growing pains?
Boy, that's a tough one because every kid responds differently and such. And I remember when my middle son, had it, growing pains. It was even though I had seen lots of kids with it, it was quite unsettling because in the middle of the night he just started screaming like someone was in his room stabbing him, and
Right.
it
Scary
could
for
be that
them.
extreme. It could be that
Yeah.
extreme. But growing pains tend to cluster, right? So
Okay.
so the kids will complain of pain at night that can awaken them from sleep. Um, and they may complain for 2 to 3 weeks, and then you got a 2 or 3 week respite where there's no complaints, and then
Okay.
comes
I
back,
better
and
get ready for this.
there's no. Well, it didn't happen to every child, but that's for sure. I had 3 kids, and it only happened to one. But
Okay.
the the key that so growing pains are you kind of it's made the diagnosis is made based on the history and things
Okay.
like that. Clustering, is it something that happens with increased levels of activity during the day, maybe a little dehydration and such. And the treatment for it is variable, whatever works for your kids. I mean, some parents
Right.
will give a little Motrin before the kids go to bed, or ibuprofen before the kids go to bed. Some will give a warm bath. Some will try warm milk and things, or a massage or something like that. There's no great way to treat it. The important thing is just to recognize it for what it is. Now,
Right.
what we worry about more, and sometimes we'll see kids if it's been persistent, because we don't like things that waken kids up from sleep at night,
Right.
right? But it's not, that's only one of many things, right? So we don't, if it's just that, and it's intermittent, and they're crawling into bed saying, my legs are hurting and stuff, that's generally nothing to get excited about. If it's accompanied by night sweats, easy bruisability, bleeding gums and stuff, we
Oh,
get a
well,
little
yeah.
more worried about that, because those can be, so indicators of something worse,
Okay.
right?
Okay.
But growing pains in and of itself, extremely common. Like I said, they tend to cluster, be episodic. Sometimes they'll respond to these other things like massage and things
Right.
like that. So that each treatment is variable based on your kid. It's as variable as your children are.
Okay. Yeah, no, that's helpful. All right, let's talk about the development of dysplasia of the hip. And I will say, maybe there's other parents out there who can sympathize with this, but one of the hardest things is when you go to the pediatrician and you watch them take your little baby and just do their hips like this. And we know it's good for them when they're checking those hips. But talk to us about just hip dysplasia and what it is, and is there anything we can do to prevent it?
So hip dysplasia just means that the socket of the hip and the cup of the hip are somehow incongruous, right? So
Okay.
meaning that it's not perfectly centered. It might be a little out, or something like that, what we call subluxated, or it could be dislocated. It's a gambit. It runs the full gambit from mild subluxation, dislocation, and even more. Some kids, newborns, have dislocatable hips that sort of just they're loose, and we think that happens because you know kids respond to maternal birth hormones, right?
Right.
And their soft tissues react in the same way. I mean, you take a pelvis and it has to open up a lot for a vaginal delivery,
That's
and
right.
those same hormones will cross the placenta
Wow.
and impact the babies. Now, girls are actually
Amazing.
impacted. Little baby girls are impacted more than boys because they're more susceptible to the hormone. And
Amazing.
so a lot of times you might have an abnormal examination right after birth, and you just make sure you don't swaddle the legs of the baby, the hips of the baby, because what you want is nice abduction so the legs are out, so that the hip can be located within the socket, and just a little bit of time. Now, if it's more than that, we do dynamic splinting for developmental
Well,
dysplasia of the hip, and it does tend to be genetic. So if you have another child who had it, or mom or dad had it, then you got to be a little more keyed into looking for it. And
mm-hmm.
more common in firstborn children, more common with the left hip. Um,
Interesting. Hmm.
yeah, and it's just based on the way the left hip tends to be up against the anterior promontory of the sacrum in utero, so
Wow,
it's a
that's
little more
fascinating.
confined. It's a packaging disorder, right?
Yeah.
So firstborn is more common because the uterus is
Everything's tighter.
tighter, yeah,
Yeah.
tighter, and so that's basically pretty much everything about DDH. It's caught early. It's usually pretty straightforward treating it. The child's in a harness, but the dynamic harness, so they can move and sort of deepen the hip, just like molding moist clay. But you have to
Right.
keep it in a
Wow.
position, what's called the human position, that allows it to deepen, and then allows the capsule of the hip to tighten up around it.
Fascinating. Dr. Grotkow, I could just listen to you talk because there's so many little nuggets. Obviously, you are a brilliant expert on this category. Now, I
I
want to
think
take a
you're
time out.
overstating it.
I don't know about that. I'm going to take a time out because I have a question. And again, audience, if you have questions related to even just kind of specific scenarios, we can put those in front of Dr. Krokhouse. So put that in the question box there. But I want to ask you a little bit about the surgery that you have developed. Let's see, I'm going back. I want to say it correctly. The groundbreaking surgery, anterior vertebral body tethering. Can you tell us
Yeah.
about that? I'm just fascinated to
So
know.
I don't want to take total credit for this. I'm sort of it was actually originally thought up by a guy that used to work for me when I was up in Boston before this, and then we've taken it from its FDA approval and sort of been improving on it since then.
Wow.
So I don't want to present me as the brains behind the original conception of it. But basically, traditional treatment for adolescent idiopathic scoliosis, which is a curvature of the spine in this plane, not from the side. That's called
Okay.
kyphosis.
Okay.
But for scoliosis, which is a
Okay.
curvature in this plane, right? So in kids who have that, and it's idiopathic means we don't know what causes it, right? So there's
And
different
is
types of
that, and I'm
scoliosis.
sorry to interrupt you. Is that like something you realize at birth? Like that would happen you would know
No,
that
it's generally a developmental. There is a
okay.
there is a infantile version of it, or early onset scoliosis, which is kind of not apropos to what we're talking about. 80% of the
Okay.
scoliosis is adolescent idiopathic scoliosis. So,
Wow. Okay.
something it's more common in girls, at least to the level it needs to be treated, probably 5 to 7 times more common in girls than in
Wow.
boys.
Okay.
But there's no neurologic abnormality associated with it. Some
Okay.
there are neuromuscular curves, there are congenital curves where the vertebrae are not formed normally. There are syndromic curves that the children have sort of genetic syndromes and stuff. They might have curvature associated with them. But this is adolescent idiopathic scoliosis. And the idea behind this is that the treatment of scoliosis when it gets big and generally above 40-degree curvature
Okay.
is a fusion where you go into the back and you put screws into the vertebra, put some rods in, you straighten it out. But the problem with
Wow.
it is that it takes that nice flexible spine and it makes it into a rigid, almost like a thigh bone, a femur. And so the spine isn't really allowed to function as a spine. If your child wants to go into the military, and you have a scoliosis fusion, or even a curve above 40 degrees, they're probably not going to let you into the military. If you have a fusion for it, they're not going to. It also impacts flexibility and sports participation and such like that. And and we think that spine fusion is kind of a salvage operation, and it shouldn't be a sort of the definitive treatment for scoliosis.
Okay.
So what we've done is that we've been working on this technology that can be done minimally invasively. At least if you have a thoracic curve, we can do it through 3 1-inch incisions in the side of the chest and use a scope, a thoracoscope to do it, and put in these little anchors across the vertebral body, and then put in a nylon cord. It's made out of something called PET, polyethylene
Wow.
terephthalate, which is like a high density mountain climbing rope. And instead of using these rods to manipulate the spine, then roughen up the spine to make a solid bone so it stays straight. This is designed to preserve motion. And the data does show that you preserve motion and you can
Wow.
still correct the curve while preserving motion. Now the beauty of it is that compared to a spine fusion, you're out of the hospital a lot faster. Your pain medicine requirements are greater. You're back to school faster, less blood loss, less risk, less
Wow.
complications. So it's got everything on the list, but you have to be a good candidate for it, right?
Right.
You have to have a
Right.
flexible curve. Ideally, you're still growing. It's not an absolute thing. We identified in a recent publication with our first 10-year experience three three ideal indications. One is that you've got a certain amount of growth remaining. A second one is a curvature between 40 and 60 degrees. Um, and and the third is flexibility of the curve of at least 50%, so that when you do
Okay.
side bending, the curve actually can correct. And if you have all 3 of those criteria, an anterovertebral tether or anterior vertebral body tether, however you want to term it, has a 100% good to excellent result. If you have 2 out of those 3, it's around 90%, right around 88% good to excellent
Wow.
results. If you have 1 out of the 3, it's about 58% good to excellent results. And if you have 0 out of the 3, it's 0 good to excellent results. So,
Yeah.
so
Zero it.
it's a good
Wow.
thing, but we don't have the longitudinal experience that spine fusion does, 60 years of follow-up,
Wow.
but we do have, we're past 10 years of
Right.
experience doing it, and we're really liking the results we have thus far. And we're the only place here in Florida doing it.
That's amazing.
Certainly one of the largest experiences in the world doing it, probably close to a little over 300 cases that I've done so far. And
Wow.
I really like it as my first choice treatment for scoliosis rather than when spine fusion.
Wow, with those statistics, I would say so. 90%,
Yeah.
100%. That's amazing. Okay, I want to camp out here for a little bit. And thank you. It stuck out to me in your bio, and I'm like, I want to know more about what all that means. So thank you for taking the time there. So while we're on this, you said it, there's no neurological, correlation here. So, but define for us, what is scoliosis? We've got some listeners who also have questions. And then at what age, again, are you able to start seeing these, maybe signs or symptoms?
So it varies. Scoliosis, as I said, if we're talking about idiopathic scoliosis, it comes in. We've narrowed it down recently to two types: early onset scoliosis and adolescent scoliosis. But traditionally we've talked about infantile scoliosis, juvenile scoliosis. So infantile is up to 3 years of age.
Okay.
Juvenile scoliosis is between 3 and 10 years of age, and adolescent idiopathic scoliosis is 10 and above.
Okay.
So again, 80% of 80% of scoliosis, but also idiopathic scoliosis, is the adolescent version. So this is why the pediatrician, and in most states you still do school screening for scoliosis. Certain states you don't do school screening anymore because there was a national task force that came out and said, oh, it's not worthwhile.
Oh, wow.
It's a free test. You just have a kid
Yeah.
bend over in front of you. So I'm not sure. I think they were worried that it was leading to too many x-rays, right? Because people would
Okay.
see curves and they get an x-ray. But I actually think you should do school screening. I do think you should, the pediatrician should routinely screen, or the family practice doctor, once
That's
a year,
great.
as you're probably about 9 years of age up to about, 14 years of age
Which is
for it.
also so important to stay up to date, parents, on those pediatrician well visits, the keeping up with those
Yeah,
visits
well
because those
child
things are
visits are
happening.
really important, not
Yeah.
just for the orthopedic stuff. There's a lot of different things.
Yeah.
These kids' bodies are changing so much in that time period that
Wild.
you really need someone who knows what's going on to take a peek at them. But so it's generally found on a well child visit. It's surprisingly, so parents sometimes see it, but that's the age when kids are looking for privacy. And if mom's checking them out in a swimsuit or something, they get all upset. And so everyone's trying to, protect each other's privacy, which is why I like the official, sort of pediatric, part of the pediatric exam, because there's an expectation of the kids that they're going to look at me there. There's not an
Yeah.
expectation that mom's going to be checking me out when I'm 12, a 12-year-old girl,
That's right.
so I think it's really important. Now, most of the younger ones, like if you're talking about an infantile scoliosis or a juvenile one, the parents seem to pick those up most frequently. They said something just didn't look right in the back, and they mentioned it to the primary care doc, and the primary care looks and goes, "Oh, you are right. Let's sort of follow this up."
Yeah. That's great. Thank you for that. All right. I know we talked about, the treatment that you offer, but are there any other new treatments for scoliosis, or we're really like, this is like cutting edge, right?
Well, so that's a surgical treatment, right? So we don't
Okay.
do operations on everybody. If they're smaller curves, so for instance, we'll just observe scoliotic curves that are up to about 25 degrees. And then between 25 and 40, we'll brace them, right? You put them in a brace,
Okay.
which has been shown to be about 60% effective in keeping a curve from getting worse. So it's not 100% effective, but it's better than doing nothing.
Yeah.
And
Is
then
the
only if
brace for always, or do they kind of like, work
for
out
the
of the brace?
brace, it's usually until they're done growing. It
Okay.
depends on what kind of curve it is, though. So that's for
Right.
adolescent curves. If you have, and we're probably going a little deep in the weeds to talk about the subtleties of infantile and juvenile curves, but
Okay.
infantile and juvenile curves, you don't necessarily brace all the way through the end of growth, right?
Okay.
But generally, idiopathic adolescent curves, you do.
Okay.
And so that's your endpoint when they're done growing and the curve is under 40 degrees.
Okay.
Then you
Okay.
can pat yourself on the back and say, okay, statistically, this is not likely to get worse.
Okay. Wow. That's great. So much, it's a word that we hear a lot about, but I think if it doesn't affect you personally, we have just such a base knowledge that that's not even enough to be dangerous. But now I feel
Well,
like you're giving
let
us.
me also say one more thing. One of the newer findings is that in curves with scoliosis, and in patients with scoliosis, if you give the kids vitamin D, there's some studies that suggest that it diminishes the likelihood of progression of a curve.
Oh,
So, when
wow.
I was up in New England, everyone was vitamin D deficient. I haven't quite
Right.
figured it out in Florida yet. But, if I had to do my kids all over again in this adolescent grade, I'd make sure they'd be getting like 3 tablets of vitamin D a day, three of the universal
Good tip.
vitamin D, because there's a lot of other things that have been coming out that vitamin D is apparently really good for. You don't want to overdose them. But
Right.
if you give 3 of the little standard gel tabs a day, starting at let's say 9 years of age to the end of growth, I think you'll be pretty happy you did that.
Okay, that's a good tip. And I think that's a good excuse for everyone to take a beach day too, Doctor's orders. Gotta go get some
Yeah.
vitamin D. Talk to us about, and we're going to circle back in a minute about more general bone health, but I want to camp here on the scoliosis for a minute. But so tell us, what is Osgood-Schlatter? Forgive me if I'm saying it incorrectly. What is that disease and how is it treated?
So Osgood-Schlatter is a subset of what we generically call anterior knee pain. There's a number of
Okay.
different causes of
Okay.
it, but it's where it's a inflammation. It's what's called an enthesopathy, right? So
Okay.
that's an inflammation of a growth plate that's under tension, right? So growth plates, most people know about. That's where your bones
Right.
grow from. There's a wrist one, there's leg ones around the knee and everything. Those are under compression, right? Because you're loading them. So a
Right.
growth plate that's under tension is called an apophysis. So
Okay.
the it's an apophysis, and what Osgood-Schlatters is basically an overuse injury of the extensor mechanism of the knee. So you see it. It's inflammation of where the infrapatellar tendon inserts onto the front of the tibia or shin bone.
Okay.
You see it a lot in kids who do a lot of running activities, jumping activities, basketball, things like that, and it it tends to be self-limited, right?
Okay.
And you can diagnose it by just pushing over that particular portion of the bone, and the kids kind of jump through the roof.
Oh, wow.
So it's inflammation, and the way to treat it generally is activity modification and ice. And what I suggest if someone has Osgood-Schlatters is that most of the kids won't stop doing what they do because it doesn't necessarily hurt while they're doing it. It only hurts
Oh,
afterwards. So
okay.
mom and dad hear about the moaning and whining and complaining, right?
Right.
So generally the parents are saying, oh, then back off, back off. And the kids, kids are kids. They don't want to back
Right.
off. So what do you do for it? Well, I usually suggest the old, I don't even know if we have Dixie cups anymore, but those little small Dixie cups we had growing up,
Right.
just freeze a few full of water in the freezer, and then they can use them and peel them
Like
down and
rub it.
just ice it for
Okay.
a period of time,
Okay.
after the activity to diminish the. So a lot of these kids also have really tight hamstrings. So stretching the hamstrings to better balance the extensor and flexor mechanisms of the knee is probably a good way to treat it as well. Now,
Okay.
the one thing about Osgood-Schlatters is that there's a like a sevenfold increase in something called a tibial tubercle fracture, where because the bone is a little bit weak, and we think what happens is the bone has a little subclinical, almost like a stress fracture from overuse, and then it remodels. You get a little bump up there. You have probably somewhere between a 5 and 7 fold increase of having this fracture when you take a big jump and land that
Ooh,
actually pulls that off. Now that's a 5 to 7 fold increase over a really, really small number. So we don't
okay.
say stop activities and things like
Right.
that, but there is a slight increase in this thing called the tibial tubercle fracture in kids who have Osgood-Schlatters.
Wow. Yeah, there is so much. Our bodies are incredible. Let's say that, what they can do. And it's just amazing. All the ways we can also get injured,
Yeah.
which is crazy. Okay, and then interesting, I'm sorry, ice, not heat. Is that in my mind? Sometimes I think, oh, I'll just put a heating pad on your sore, whatever.
Well,
But
so
because
there's never
inflammation?
been any credible evidence to support one over the other, right?
Okay.
I like ice because it numbs things and it takes the pain away. But
Right.
if heat works better for you, then go
Okay.
for it.
Okay. Great. Talk to us about the role of physical therapy in pediatric orthopedics.
Yeah, I'm a big proponent of physical therapy, right? So a lot of things that you treat with operations in adults, you don't in kids, right?
Mm-hmm.
Um, in fact, there's an interesting number that on average, an pediatric orthopedic surgeon has to see 40 patients to get one operative case, right? And we're surgeons, right?
Yeah,
While
right.
our total joint colleagues see 2 patients and they get an operation.
Wow.
All the others are somewhere in there. So we do a
Okay.
lot of non-operative therapy, be it for fracture
Okay.
care and stuff like that. You rarely see casts on adults, because if they have a forearm fracture, they get operated on with good
Right.
because they have better results. With kids, you tend to treat things a little more conservatively. So the oh, I didn't even remember. What are you talking about? I
The
kind of a
physical
little field.
therapy. Yeah, the
Oh, physical
proponent of
therapy. Oh
physical
yeah, so
therapy.
physical
Yeah.
therapy. So there's a lot of things you can make better with physical therapy in kids. For instance, back pain. Back pain is fairly, common in kids and
Okay.
especially in adolescence as such. And I will tell you that most of the kids with back pain have super tight hamstrings because it causes them to flex their pelvis,
Oh,
so they shift their center of mass forward, and the muscles in their back have to work a lot harder. And so, doing core strengthening, back strengthening, hamstring stretching and stuff is really good for that. Things like anterior knee pain, physical therapy is really good for that. Getting the hamstring stretched out, the quadriceps strengthened, patella maltracking, kneecap maltracking, really common causes of knee pain in kids. So PT is really good, and a good PT is worth their weight in gold, right?
oh,
So it's really important, to find a good PT if you have a kid that needs it.
okay.
You don't necessarily have to go to a specialized physical therapist, and the for kids or something like that. General physical
Okay.
therapists can do it,
They
but
can.
I really
Same
think
for
it's
PT.
critically important for kids, when they have an injury.
Oh, that's great. That's great. All right, I want to circle back. We kind of zoned in, but now I want to go big picture again and talk about overall children's bone health. What can we do to support? I know you said the vitamin D, which is a great. I'm walking away with that. And
Yeah.
how? I mean, is there a certain milligram? I mean, you said just get the kids vitamin D's.
So
Is
no,
it?
so there's vitamin D comes in a universal standard preparation. So
Okay.
little capsule, and I think it's probably 1,000 milligrams. I can't remember, but
Yeah.
there's really small gel capsules, and
Okay.
and so generally, if you give them 2 to 3 of those a day, they're pretty small, easy to swallow, smaller than an M&M.
Oh yeah.
That's perfectly fine. You don't want to go nutty with it. It's not a thing where boatloads more is better, right?
Right.
So
Is it a
so
certain
that
age you would say start it here into there?
I talk to your pediatrician more
Yeah.
about that, but
Right.
my thought is mainly because so many of the kids, we were doing a study up there and looking at all of our fracture patients that came in, and we found that probably 90% of them that came in with some sort of a fracture, kids that were vitamin D, had low levels of vitamin D.
Wow. Yeah.
So I
Interesting.
don't know, we don't know enough yet to say
Yeah.
that they wouldn't have fractured had their vitamin D been better, but it was just
Can't hurt.
eye opening the number of people that had low vitamin D. But that's
Absolutely.
New England. I mean, it's not Florida.
That's right.
Yeah.
Anything else you would suggest just for general promoting bone health?
Yeah. So weight bearing activities, right? So, if your kid's a gamer, they love gaming, that's great, but make sure balance that with some activities,
That's right.
and not everyone wants to play organized sports. Organized sports is good for socialization and certainly muscle and bone health and everything like that. And so I would absolutely make sure that the kids are getting at least an hour of some sort of good exercise a day.
That's good. That's great. Love that. Get those kids outside. Something I'm super passionate about. That's great. All right. We talked about growing pains. So we're going to move on from there, but let's talk about now fractures. And we're going to talk about growth plates and all that. But what are common signs of a fractured bone? Because I think every parent has probably felt the like, how do I know if it's fractured, if it's not? Do I take it to somewhere? What do I do?
Well, crying,
Yeah.
it's always a big one. So, no, so after a fall and stuff like that, basically tenderness to just feeling over the
Gotcha.
the affected place. Sometimes you see warmth. Yeah, it's kind of a little more obvious sometimes when it's a displaced fracture. There'll be angulation, and God forbid the bone sticking through the skin, which is an
Oh,
open fracture. Those are kind of the obvious things that you probably don't need me to talk about. But
right.
really, it's kind of persistent tenderness over the bone, right?
Okay.
One of the things that's not that we miss a lot is like elbow fractures because they're very hard to diagnose even on X-rays because the elbow is largely cartilaginous until you're
Okay.
until you're older. So it takes a really good eye to look at that. And in fact, when I was doing a fellowship years and years ago, my nephew, I was out in California and he was on the East Coast here, and he fell, and his parents sort of said, rub some mud on it, you'll be fine. He ended up having a supracondylar fracture for a couple of
Oh
days before
no.
they had it operated on. So it's they're easy to miss, but tenderness is probably the biggest thing, associated with
Yeah.
a fall and
Yeah.
or some other sort of injury, uh, deformity, and generally not redness or anything like that, but swelling is certainly one as well.
Okay. Okay. What is here's a question, just like we hear about like a bone spur. What does that mean? Or what is that? Is that like if you leave something untreated, is that an issue?
Yeah, so bone spurs generally aren't that big a deal. They're usually calcification in a tendon. Like I said, those ones that are under tension. Sometimes if they get injured, like at
Mm-hmm.
the heel or something like that, or at the elbow, you can it'll bleed a little bit into it, and then the blood that gets there will calcify or ossify,
Interesting.
and you'll get a little bit of a bone spur there. They generally don't tend to be too painful, but
Okay.
every once in a while, it'll cause some sort of impingement, and then you have to remove them. I'd say the most common place you get something like that is with that Osgood Slaughters, right?
Okay.
So sometimes with that Osgood Slaughters, as the kids get older and it should be getting better, there's a very small segment, like less than 5%, who won't. And what you see is a little ossicle there, an extra little bit of bone, and you might colloquially they'll call that a bone spur. And if they persistently, if their growth plates are closed and they still have that same sort of pain, sometimes if you just go in there and you excise that little ossicle of bone, then they magically get all better. So there must be some little bit of motion in there causing discomfort.
Wow. Wow.
Yeah.
Okay. So many things. Okay, let's talk about spinal alignment. We talked about the scoliosis and then kind of just recapping, but when we should be concerned about our child's spinal alignment. You're saying not really until we see what are kind of like the okay, now I should be concerned.
That so I have a saying in our office that don't ignore a tip from the jockey, right? So
Yeah.
so if mom comes in and says something's wrong, I always assume something's wrong until I can prove it's not, right?
Okay.
So because
Mamas
I've seen,
appreciate that. I appreciate that.
well, I mean fathers too, I guess, but usually fathers are just the chauffeurs. I hate to be sexist, but I was that too. We go to an appointment with my kids, and my wife said, "Just keep your mouth shut." I'm like, wait a second, but I'm a doctor.
Wait a second. I'm the mom. Be quiet. No, I'm kidding.
So so in terms of looking at alignment of the back, I'm not going to suggest you constantly check out your kids and stuff, because you'll pull your hair out,
Right.
and they're not going to love you for it if you're constantly doing that. But I would just remember that if you had scoliosis, if you're a mom and you had scoliosis, or the dad had scoliosis and stuff like that, primary relatives, meaning that your children or your siblings have a higher chance of having scoliosis. So you just want to remember that and mention it to the pediatrician or primary care doc and say,
Good.
hey, listen, can you just keep a little closer look on things
Right.
and such?
Right.
So,
That's good.
so but what do you see? Since scoliosis isn't just a bending of the spine, it's a three-dimensional rotation of it.
Wow.
What you're
Yeah.
seeing and what really gives you the evidence for scoliosis is you're seeing the ribs, at least in the thoracic spine, pushing up, right?
Right.
Because it's like me having my hand out here. If my spine is just my body not moving very much, but my hand way out here is
Oh,
moving a
yeah.
relative lot because it's far away from my body. In the
Right.
lumbar spine, the what you're seeing are the paraspinal muscles being elevated a little bit. So the way
Interesting.
we look for scoliosis is we generally have kids bend forward with their knees straight, and you're looking for um, rib humps in the thoracic spine, or a little prominence in the lumbar spine on the other side. And that's basically how you check for it.
Wow. Fascinating. Fascinating. On that note, at what point should we determine that maybe our child needs to see a pediatric orthopedic specialist?
Well, it depends on what the concern is, right?
Right.
So we talked a little bit about if you have a kid who's really delayed in walking, you might want to come in. If you have concerns where we're talking about developmental dysplasia of the hip. One of the things that when you're checking for that is, as the kids get older, if the legs are at different heights and things like that, you're
Mm-hmm.
worried that could a hip be subluxated. In slightly older kids, a lot of times when you lay them down, the abnormal hip, if there is one, will not move out as much as the other side, right? It's called
Interesting.
less abduction. So
Okay.
things like that. Certainly, if you think there's been a significant enough injury or a fracture or anything, if you notice a curvature in the back, um, you know, pain that isn't getting better in a reasonable amount of time.
Mm-hmm.
Overuse injuries, like kids that are in sports and such. Um, throwing sports and stuff who have shoulder or elbow pain, or anyone who's got acute, let's say, knee injury or something like that after sports participation. You worry about things like ACL tears and meniscus tears, and they
Wow.
even happen in young kids. Um, Kids
Wow.
who have persistent low back pain that hasn't responded to backing off of activities and stuff like that. Kids can get young kids, not super young usually, but 10 and above can get disc herniations just like adults get. They can get something called the spondylolysis, which is a stress fracture in the back, especially if they do repetitive hyperextension activities like tennis,
Oh, wow.
gymnastics,
Yeah.
and inside linemen in football, wrestling, sometimes
Okay. Yeah.
divers, things like that. There are a lot of things, and that will often cause persistent low back discomfort that sort of doesn't respond to the usual rest, ice, it's the rice protocol,
Right. Right.
and then return to sports, any of those sorts of things.
Okay, yeah, that's helpful. I do want to talk a little bit about the sports because I think that's something that we all are always thinking about. Before we do, I want to know, what do we do if we suspect maybe our child has like a growth plate injury? You mentioned those areas where there's growth plates. Obviously, that would be a more significant injury than just a regular fracture.
No, I think they're pretty on par. It's just that you don't
Okay.
want to miss a growth plate injury, right? So you
Okay.
don't want to, you want to appropriately
You don't want to put
immobilize
mud
it.
on it and say move on,
Yeah,
right?
you don't want to just spit on the mud and just put it on it. So, you just want to make sure that they're appropriately immobilized, because, the thought there is that with the growth plate being cartilage, if you leave micromotion and everything, what can happen is that just like sandpaper across that growth plate, it can potentially injure it and cause it to close prematurely. And then you either get a shortened extremity or an angular deformity because
Okay.
one side continues to grow. So yeah, so growth plate injuries are something that we sort of look for,
Yeah.
but they're just as they're fractures just like almost every other fracture. It's just that
Okay.
it's a little weaker point in the bone in kids.
Right. How many, this is digging deeper, but how many growth plates are there throughout like a child's body? There's a lot.
A
I mean,
lot.
forgive my ignorance.
I don't know the
Like, are we
exact number,
talking
right?
10? Are we talking 50
No,
or
you're talking. So every long bone has
gotcha.
growth plates, usually on both ends.
Makes sense.
Yeah,
Okay, great.
and some have multiple, like the femur have three,
Okay,
three or
see, this is
four.
why you're the
Yeah,
expert. I'm just here to
yeah,
ask the questions, clearly.
yeah.
I appreciate it. Okay, audience, I've got some more audience questions coming in. We have got just about 10 minutes. So if you have a question for Dr. Grotkow, now is your chance to submit that. We do want to talk now about sports-related injuries because I think this is something that it's affecting a lot of us. Kids are playing sports, it seems, younger and younger. So how can we help prevent sports-related injuries for our children?
So there's a couple of really important things to do. So, and it depends on the sport, right?
Right,
So, we've all heard of pitch counts in baseball and stuff like
right.
that, and then, but some of these kids, each league, some of these kids that, let's say, play baseball, I'm just going to, they're in three different leagues, right? So every coach says, well, but he's a good pitcher, and I got him under the pitch count, but it's up to the parents to
Yeah.
be really, the advocates for their kid to avoid
Yeah.
injury, right? So important thing to know is that no kid that, I still think this is true, that was pitching in high school was ever pitching in the majors, right? So if you think your kid is going to be, they end up throwing out their shoulder and their elbow.
Oh, yeah.
So if your kid is really good, you don't want them constantly doing pitching. You want them to play around. So, but what more practical from a point of view that comes back is that cross training is really important, right? One of the areas that we see the highest level of injuries is, believe it or not, gymnastics. And I don't want to make people mad, but in the office, I call gymnastics sanctioned child abuse. Because these, so a lot of times you see, now, I think parents are getting a lot better about this, but, you have to, so a lot of people were really interested because there's just a really odd way that gymnastic works is they level these kids, right? Up through
Right.
level 10, and then you become elite, and then you're working your way up, and then you have visions of college scholarships, Olympics participation,
The
and stuff like that.
podium.
So you have to be really careful not to give over the well-being of your child to a coach,
Wow, yeah.
because most
Yeah.
coaches are great and they realize these kids have another 80 years to live. But
Yeah.
sometimes we don't have the same objective, right? As parents, we have to step back and say, my job is to get them to the end of their lives, right?
Yeah, that's good.
Not to the next meet or next championship,
Level,
right?
right, right.
So I think we have to be active and
That's good.
not necessarily give our kids over to the coaches. The second thing is especially in younger kids, like for things like soccer and such, if they're playing on a natural field, a lot of those things have big holes in them. They aren't really well maintained. So what we used to do is we used to walk the course before our soccer game and look for holes, and then tell people that ran the facility we need dirt to fill them in and stuff like that. So
Yeah,
you want a safe to play area, right? You want to
great.
identify, hazards and equipment. Like your kids playing football, and I think most football, you know, places are good about this. Leagues are good about this. They replace their equipment more frequently these days. But it used to be, just old, out of date equipment, which would increase the potential for injury and things like that. So it's really taking a more active role, and then
That's great.
flexibility, right? The
Right.
kids a lot of times get injured because practice field time is at such a premium in most places that
Yeah.
coaches say, listen, we've got an hour to use this,
Skip the warm up,
we're going to
right?
use it. Yeah, you skip the warm up, right? Skip the
Yeah.
stretching either before or after. And I think it's really important to do, especially as kids are through the rapid phase of growth.
Yeah.
The bones grow quickly and the muscles and tendons get pulled along kicking and screaming, and they
Yeah.
get tight.
Ooh, that's good. I feel like we could do a whole episode on just the sports related injuries
Oh
and
my gosh,
development and
yes.
all of that. So maybe we can have you back, Dr. Greco. That'd be awesome. Wonderful. Okay, we've got some questions from our audience, and I'm watching our clock because you're going to get out here in just a
Okay.
few minutes because you've got an appointment. All right, let's talk about one audience viewer says her 5-year-old has bone pains at night at least 2 times per week on his legs, below the knee to his foot. Please advise. I think we talked about this. So give her, a recap on that.
Yeah, that sounds very much like it's as long as there's not easy bruisability, gum bleeding, night sweats and things like that, then it's probably just growing pains.
Great.
I would experiment with different things. I'd say, well, maybe we'll give a little pediaprofen before we go to bed, this week and see if it helps things. Or a nice warm bath if you want to start a little more holistically, or a warm cup
Right.
of milk if there's no milk intolerance and things like that, or a massage, and see if any of those things, but don't do them all at once, right? Figure out for you what's the best way, for your child, what's the best way. And that's kind of how I would handle that.
Yeah. Oh, that's good. I had memories as a kid of waking up going, why are my legs hurting? So I remember that. I sympathize with that. All right, here's another one. A 6-year-old son had a hip
I slept
fracture.
like a rock.
Yeah,
Oh,
must be nice.
sorry, go
You
ahead.
said it doesn't happen to everyone, so lucky for you. Okay, this viewer said their 6-year-old son had a hip fracture in February playing soccer. The doctor told us he's fine. The fracture healed correctly. This listener wants to know, can a hip fracture affect him as he grows?
So it depends on what it was. So without knowing what it was, there's a lot of different hip fractures. Now, how is it? What was the age?
Six,
Six
six-year-old.
years old. So generally, that sort of thing is like an avulsion fracture or something like that from the pelvis. And generally, that is not something that you worry too much. Now, if it's a femoral neck fracture or a stress fracture of the femoral neck, as long as it's not displaced, it's not likely to cause a problem or anything like that. Now, if it's displaced, you can get problems down the road, especially if it needed to be operated on. Because you can have a transient loss of blood supply, and that can cause something called osteonecrosis. But my guess is we would have heard about that if it had been an operation. So it's unlikely to cause a problem over the long term.
Okay, great. Our audience is firing up here right at the end. So I'm going to do some of these in a lightning round for you, Dr. Krakow. All
All
right,
right.
here's another one. 2-year-old son constantly complains of pain in his leg and ankle for several weeks. Should we visit an orthopedic? Does that also sound like a growing pain scenario?
It does sound like a growing pain, especially if it's bilateral. We worry a lot less about bilateral stuff. But with the caveats I already said, as long
Yep.
as nothing else seems to be going on, I would sort of step back because usually these things sort of resolve themselves over time.
Okay. Here's
And
another
what
one.
period of time I can't tell.
Right. Okay.
So it's variable.
Also, see your healthcare provider, all those disclaimers. Yeah.
Yeah, yeah.
Okay, what about this one? 11-year-old often complains of pain right in his inner thigh. Is that growing pain sort of area?
So generally that wouldn't be growing pains. So
Okay.
it's like the groin region.
That's
It
inner
sounds like
thigh.
it. Well, so okay, I'll just pretend it is the groin region, the inner thigh. A lot of times we think about that as something intracapsular within the hip joint. So if that's a complaint that's activity related or just constant, that is worthwhile seeing someone about, right?
Okay.
Because
Yeah. Like
especially if the
groin.
kids are overweight, like really overweight, you can get something called a slip capital femoral epiphysis that needs to be addressed, you know, soon.
Yeah.
And so groin pain, we were concerned about intracapsular problems, like a slipped epiphysis
All right. You should
or
give a call,
a
baby.
labral tear or something like that.
Awesome. We'll make a plug for the Shriners Children Orthopedic Center at UHealth Jackson Children's Care. Okay, here's one more. I'm watching our clock, so you are not late. A
Sure.
four-year-old has complaint about a pain in one foot. They've done x-rays. It looked okay, but the pain persisted. The pediatrician to send him to the x-rays took some time to convince the pediatrician because of the radiation exposure and because it was not a terrible pain, just a complaint. They took him to a specialist, but they said it could be growing pains. How can we be sure or more clear on what's happening and moving forward?
So it's probably not growing pains in that situation. What I would tend to do in that situation is I'd put the kid in a cast for a few weeks and see if it quiets down because sometimes it just needs a
Just
little bit
sit.
of rest and to see if
Okay.
that impacts the discomfort.
Great. We lightning round through those. Great job,
Oh,
Dr. Grotkow.
good.
Audience, thank you so much for your participation. This was an exceptional episode to be able to glean so much wisdom from you. We appreciate your time. We know you've got to head out here for a surgery, so we wish you all the best in
And
that.
I didn't
And I
plan the
would say,
surgery. I didn't. This was a femur fracture in a football player. So
oh
it's
man,
unfortunately,
oh
yeah,
man. I'm telling you, we got to have you back for a sports injury related
yeah,
episode because I think we've got lots to cover there.
right.
There's some additional resources here for our audience if you want to screenshot this to do a little further research.